Hello and welcome to the channel. This is Dr. Prashant Shukla, and today I'm here with few of my early experiences with the B-Hex ring. Here we have a patient who presented to us with gradual diminution of vision, and he's a known diabetic for more than 15 years, and his age is about 50 years, and he needed a cataract surgery. With best of pharmacological agents and intracameral adrenaline, we could just achieve a dilatation of about 2.5 to 3 millimeters. And so I have planned to use a BHex ring in this case. By this time, two side ports have been made. Entry capsule has been stained with trypan blue dye, and dispersive OVD HPMC has been placed instilled into the eye. Now is the time to make the main 2.8 posterior limbal main port. A triplanar incision is planned. Viscoelastic is then placed under the iris to make some space for the BX insertion. BX is then held with one of the flanges with the help of a BX forceps, and it is then tucked under the iris. It is a good idea to use a second instrument to stabilize the eye and keep it in primary position. The right sided side port is then used to tuck the opposite flange. In this process, the primary flange got dislocated from its site, which is then repositioned using the B-Hex forceps from the main port. Some more viscoelastic is then instilled into the eye, and finally the left side port is then used, and BX forceps is then inserted inside. The flange is held, and it is the BX is tucked under the iris. This is how the pupil looks after all the three flanges have been properly inserted, and the BX is fixed in the eye. A 26 gauge cystitome is then used to lift up a intracapsular flap. In this case, I have used multiple instruments to create a rhexis just for my own personal comfort. Some more HPMC has been instilled because the chamber was getting shallow. Here I am using a capsular rhexis forceps, Dr. Haldipurkar's forceps. At this point, the rhexis gave me a hint of running to the periphery, so I stopped here, refilled the chamber. Now I am taking a microcapsular rhexis forceps through the side port. I held the flap and pulled it towards the center. And then continued the rhexis partially below the iris. And here the rhexis is complete. Now is the time for hydrodissection. Small bolus of BSS are passed using a 27 gauge cannula. The nucleus is then tapped and all the trapped fluid is then released. A cortical cleavage hydrodissection has been performed. Now is the time for the phaco probe to enter the eye. Here I am planning to do a stop and chop technique, a slow surgery with low parameters and a low bottle height of about 80 centimeters. The vacuum being used in sculpting mode is about 75. Phaco power being used is 60. Some of the superficial lens matters then is first removed and the sculpting or trenching of the nucleus is started. The procedure has been done at a very slow speed. Gradually and after sufficient depth is achieved, the nucleus has been cracked now. Because of the spongy nature of the cataract, due to long standing diabetes, it was difficult to crack the nucleus into two pieces. And now I have planned to use two Sinsky hooks to manually separate the two heminuclei. The two Sinsky hooks are then used from the side port, and a cross chop is being performed, and two heminuclei are being separated. Phaco handpiece is embedded into one heminuclei, and a direct chop is performed. The heminuclei is then further subdivided into multiple pieces, and one small piece which comes out of the bag is emulsified. It is a good idea to emulsify the first piece in such cases to have some space in the capsular bag for proper rotation. Now is the time to replenish the OVD into the eye. Again, the separation of the fragments is confirmed using Sinsky hook. Phaco handpiece is then inserted again. The heminuclei is then held sub-chopped. The vacuum being used in this case is 300, Phaco power 65, and the bottle height is 100 centimeters. This is a Venturi based machine being used. The surgery is being performed as at a very controlled speed and rate. The fragments are not being allowed to just jump off and hit the corneal endothelium. With minimum chatter and proper power settings, nuclear grade of about grade 3 plus with a spongy consistency is slowly and gradually removed from the eye using the phaco handpiece. The last bits of nuclear fragments are now being removed. The side port instrument is withdrawn from the eye to make the chamber deep. The vacuum settings are lowered to about 200 with the last piece. Slowly, the last piece is removed. Now is the time for the removal of the cortical matter. Although in this case there is not much of cortex which is there, a small nuclear fragment got stuck at the tip of the coaxial handpiece is now being removed. Here I am using a Sinsky from the side port just to lift up the iris and see for any remaining cortical elements. All the cortical matter has been removed. The eye is now filled up with viscoelastic, and now is the time to implant the intraocular lens into the eye. Here goes a single piece hydrophobic aspheric foldable intraocular lens into the capsular bag. The haptic is then maneuvered and dialed into the capsular bag in proper orientation. Iris is being lifted just to check that the haptic has gone into the capsular bag. Again, the retroillumination mode of the microscope is being used to recheck and assure that the haptics are into the capsular bag, because hydrophobic lenses are not very well supported in the ciliary sulcus. Haptics of hydrophobic lenses are thicker and they can cause UGS syndrome into the eye. So it's always a good idea to recheck and assure and confirm that the haptics are in the capsular bag. Now the BHex forceps is used to disengage the BHex ring and it is removed from the eye. Inserting and removing the BHex ring from the eye is a very easy process, a good process, and we don't have to actually make any extra side ports or extra incisions. It very well goes through the main port and comes out very easily without causing any problems or injuries to the intraocular structures. BX also doesn't cause any excessive stretching of the pupillary sphincter, and there is no or very less chances of any injury to the pupillary sphincter. And at the end of the surgery, one can have a very round pupil as if we have not done anything. All the viscoelastic is now being removed from the eye, both from the front of the lens and from the behind the intraocular lens. And this is how the eye looks at the end of the surgery. Hope you enjoyed the video. Please do like and subscribe this channel if you like the video. Thank you for your patient hearing.